Well, yesterday was such an invigorating day. It was really exciting, and I think we're all happy to be continuing this symposium today. Our session this afternoon, this is the fourth and final session, is called Preventing Work-Related Illness in Construction Workers. And we have four speakers with probably, 5,000 years of experience crammed into these four lives. When I read their bios, it's quite overwhelming. So our speakers, we have four speakers, Anders Englund, Carol Rice, George Peligian, and Denny Dobbin. And our first speaker is Anders Englund, and he comes from Sweden. His talk is called Health Risk Among Construction Workers. He served for 10 years as the Director of Medical and Social Affairs for the Swedish Work Environment Authority, and has been involved in health and safety issues in the construction industry as Medical Director of the nationwide Occupational Health Service for construction trades established by Swedish social partners. He's served on many boards having to do with cancer prevention and cancer control. He is a fellow and previous executive board member of the Collegium Ramazzini, and in 2006 was awarded the Ramazzini Prize for Preventive Work in Construction Work, Safety, and Health. So I present Dr. Englund. And Executive Director of UICC in Geneva. Thank you. Many.
Thank you very much. Well, as I am the oldest one in the panel, I suppose, and we were all together 2000, you can imagine how old I am. Well, first of all, thank you for bringing up this issue of health and safety in construction. It's a theme rather often forgotten, and I'm very thankful to have been given the opportunity to contribute to this meeting. So, oh, thank you. At the hotel we are living across the street, they are building a house, a residential house, 4 or 5 stories high, and I was really very surprised to see that there is a magnificent modern crane bringing things up to the highest level, but there is no safety precaution whatsoever. No hard hats, no fencing to prevent them from falling down, a very simple wooden piece for climbing up, etc. So I imagine if this is what it looks like here in the middle of the capital, it might be rather poor safety thinking in the construction trades outside in the country as well. Residential and commercial houses is of course an important part of what is done in construction industry. A lot of infrastructural activities going on, and I'm just going to show you, as I find, 3 wonderful slides showing how construction industry is dealing with everything between sky and the earth level and even beneath. This is unloading concrete at mountain station up at the Mont Blanc in the Swiss-French Alps. This is a bridge connecting Sweden with Denmark and the European continent. And this is even beneath the earth level. It's the French entrance to the channel to Britain while it was towards the end of its construction. There are some characteristics which are important here to keep in mind. The work sites are non-permanent, locations are changing, and in particular hazards are changing as the project proceeds. And in general, in most countries, the employees are short-term affiliated, employed, and not permanent. And they are changing employer when they go to a new project. What I'm going to talk with you about is how we have in Sweden, back to the end of the 60s, which means some 45 years perspective, been dealing with these things, and it might be appropriate to talk a lot about the past, when I see what I see from the hotel opposite the street about the conditions here in construction. There are three areas to discuss: accident prevention, prevention in field of ergonomics, and to this I also include noise and vibration, and then prevention in the field of the chemical hazards. And as you know from the program, we are going to have additional in-depth presentations on both ergonomics and some of the chemical hazards I will mention. Starting with the fatal accidents, European 15 is the old group of countries, and as you can see, in addition to construction, it's agriculture and transport that has got the high incidence rates of fatal accidents. If you just compare construction with the rest of the industries, you can see that it is just about half. It's the red line here. It's double the incidence of the rest of the industry. And if I take my own country, Sweden, and looking back to the early 80s, you can see that we used to have something like 20-25 fatalities a year, and that you could have seen on other pictures that was a pretty good figure in European circumstances. Lately then, from the mid-early 90s, they are just about half, and that looks very good, say 12 a year. There was a very interesting remark from the president of the Construction Workers Union just a month ago when they were in the middle of their negotiations about salaries and working conditions. He said, in which other sector of activity in our country would you accept and be happy with one person being killed at work every month? You wouldn't even in other high-risk operations. So then we have the non-fatal accidents, and there you can see that Sweden, which is quite to the right, has a fairly low figure, and countries like Spain and France are pretty high. Luxembourg is a bit strange. I mean, they don't have any construction workers themselves, more or less, I think, because they are coming from outside working in this small country. So my point here is that statistics on non-fatal accidents are much more difficult to compare. And as you can see here, it's the same countries, but there are different age periods, and they differ a lot up and down. And changes in regulations in the insurance scheme mean a lot to the actual figures for a particular year. Again, here is Sweden is very low. The Netherlands, do you see that here? Is a very low country. That's it. The Netherlands is a very low country, for instance. And the way the social insurance is taking care of the suffering people means a lot to this type of statistics. I think this is a very interesting slide, which I got from an American friend, showing how the fatal accidents have declined somewhat over the years, but the non-fatal ones have declined much more. And that's a bit strange. You would expect them to be, in a way, parallel. And the explanation from some of my friends there is that this is mainly due to less reporting, because if you report, you get in a bad shape. You pay more to insurance. You are less likely to get the good jobs, because the whole system of getting a job in federal agencies, for instance, is to show a good safety record. I will give you a few examples from our own area that you can do things safely. As you see here, 6,000 man-years, not a single accident. That's a real figure. I have myself been walking down this slope when it was almost ready. It's a bridge up in the north of Sweden, and it's a wonderful river that it is covering. The reason why this was such a good safety example is that the guy who was in charge of the whole operation was very careful on safety. Whenever he got a new person coming in, he took them into his office, told them about the safety rules, and he said, if I see you out there without the hard hat once, I give you a warning. If I see you twice, you are gone. This is the bridge I showed before between Sweden and Denmark. And this is interesting because there were two different contracts over these periods. And as you can see, by the way, the previous bridge was built in the early 90s, and just after came this bridge. And in fact, this contractor, which had such a good record compared to that one, was managed by the same man who did the previous bridge. So the way you treat this is of importance for safety. At any time, day, any time, anywhere in the world, safety is a clear-cut barometer of organizational excellence. There can't be an excellent organization that has a lot of accidents. These are words coming from India, imagine. So my point here with regard to accident prevention is that the people in charge at the work sites should be able to handle that by themselves. However, when we get to the ergonomics and the chemical hazards field, then you need assistance. And you mentioned yesterday when you talked from WHO that occupational health services are an important tool. In the European Union terminologies, multidisciplinary services. And already 45 years ago, as you alluded to, the social partners in construction industry in Sweden decided to make such a multidisciplinary service, occupational health service, covering the whole country, all trades. And these are numbers of the experts that were involved. And to be able to make the type of health surveys that you also mentioned in the WHO presentation yesterday, there were mobile units, some 12 of them, covering the whole country in addition to the stationary places. And the medical examinations data here have been used for follow-up in epidemiological surveillance, matching it with cancer registry, like we heard from Norway, with mortality figures, etc. And the data from these examinations were from the very beginning a very important tool in telling the industry what the problems were. And I will come back to a very good example of how it was being used. We tried to describe the environment with a kind of profile. 5 is the highest. Squares are measured. These triangles are assessed by experts like physiotherapists, engineers, etc. So that was a way of trying to categorize which were the worst. This man was working in the end of the 60s, I would say. You see, it is not a good working situation. No hard hat, no respirator, vibration indeed, no noise protection, and a bad back. And that's what we started with. And I hope that you are not still in this country on this level. If you are, you really have to move ahead. Very early, the first year or so, 40,000 examinees from those buses and stations, we found that the bricklayers were having a high rate of low back pain. And other measurements made show that it was quite a difference to work like that compared to working like that, not having to bend so much. So what was done was arranging a kind of gliding scaffold on the side of the wall. This is what it looked like. So the man could use taking the block, the brick, and the other things and put it in place without having this trouble. Later on, in the late 80s, early 90s, much more sophisticated data were taken up, and again you can see here that the bricklayers are pretty high, but the floorers, and in particular the roofers and the scaffolders, were even higher. And if we take the neck disorders by occupation, you can see that crane operators had a big problem because they are sitting like that, as you know. Insulators was another group with a high rate, and the painters, you can imagine they work like that, and again the scaffolders. One type of activity was welding, particularly for the pipe fitters. And when they worked in the conventional welding, which was just up under the ceiling, there was a lot of load on the upper extremities, but also here. But another welding way, like this, gave a much more favorable situation for them. And now we come back to this gentleman. If you went to the end of the 80s, this would be what it looked like. Of course, there was a hard hat and the noise protection, and above all, the vibration and the back load was taken away. Of course, you can't take this big machine in every little place, but as you can see, it's possible to bring it in quite small places. I mentioned that noise is an important problem, and an important problem in construction because it's not as you can do in stationary industry, you just get the noise away. Here the noise will always be around, so you really have to take care of the personal protection equipment. And at the same time as people had their medical examinations, they also were trained, informed by our nurses that they should use these. And in fact, measurements like hearing capacity, and by the way, even the respiratory tests were used as a tool to persuade the workers that you need to be careful here. And here you can see the difference between the first couple of years and a 10-year, 15-year period later. And in the age groups where you really had an possible impact, you can see that the rate of severe hear capacity has improved a lot. So if we go to the chemical hazards, we have to think about the skin, the respiratory tract, and the central nervous system. Skin, I would say that it's the cement and the isocyanates that were our problem. The skin cement, there were 2 points here. It was the chromium-6 caused allergic reactions, and it was the alkaline character of this wet cement. The chromium-6 cement was handled in all the Scandinavian countries very early by adding ferrosulfate and reducing the chromium-6 to chromium-3, and you got rid of the problem. Later on, Germany followed with the Waldberufsgenossenschaften, and later on, much later on, you got the whole European Union. I have always been so surprised that it has been completely impossible in the United States to get the industry add the ferrosulfate and the chromium-6. I followed it closely as a technical advisory board member of the CPWR, and I always come up with a question. And Portland Cement says it's impossible. Europe has shown it is. Respiratory tract, we have heard already yesterday from in the presentation of the lung diseases that cement dust and silica dust, etc., is causing COPD, and we also have some of the cancers here. And with regard to asbestos, I will come back later on. Central nervous system, solvents, you know, solvents in paints was a problem for the painter. And again, in Denmark, Sweden, Norway, Finland, very early, it was decided that we have to change from solvent-based products to water-based products. And it was even programs to retrain the painters to use a new type of products because they were not happy with the results they got before they were taught how to do it in another way. So this was a very important and very successful step taken. You are not supposed to read this, but this is in fact what it looks like if you try to plot the different construction work types and different chemical products. You see, it's like shooting, and some of them go everywhere, and like noise and some others. But this is just to illustrate that construction industry is a very complex industry in this respect. The lung carcinogens in the construction industry, I don't have to repeat those because it was nicely presented yesterday by IRC, but I wanted to add painter, because painter as a trade is also in one of those monographs. We have, as I said, followed up the records from the medical surveillance system with cancer registry and found our own data, which I come back to. But I also fairly recently made a paper for the European Journal where I summarized cancer in construction industry from other sources. And I would say that all types of studies from different parts of the world show excess cancer in construction workers, which is compatible with what we know about the exposures that I mentioned before. Cement and silica dust exposure, you have the lip, pharynx, esophagus, stomach, etc., and you have, of course, in particular, respiratory cancers. And the asbestos exposure is associated with excess of the larynx, lung, and pleura, as we discussed yesterday. And above all, I think you could say that the asbestos exposure causes the highest risk in the construction industry and should also be the easier one to eliminate, at least in the first place. You don't introduce it any longer, as we and Europe didn't. This is what it looked like typically in the 70s. You were sawing the cement, asbestos cement sheets. This is a slide, as you can see, from Professor Voigtlich's group in Gießen. This is what it looks like nowadays when you have to safely take care of what has been installed long ago. And I would say in Europe, the European Union, this is a phase that everything is concentrating on now, because since quite a number of years, the new, fresh use have been forbidden. I'm just wanting to put emphasis on the first line, which means that the consumption per capita is the highest in Russia. And I'm afraid it still is, because most other countries have now abandoned it, and it has been more and more difficult even for the Canadians to export. China, of course, produces a lot, but with the billions of inhabitants, gets less per capita. Some of the Asian countries are still high. But why I mention this is, as you so long belong to this Russian system, I am convinced that there is an extremely large amount of asbestos here. Because in Russia, it is believed that it is not a health problem. The Canadians, they realize that it is a health problem because they don't use it at home. They just exported it until very recently. But this is why you should pay special attention, I think, to the asbestos problem in this country due to your historical past. Here we can see, in Sweden we had at a maximum 20 million tons, which is very little, of course, a proportion of the world consumption. But what is most interesting here is a very narrow period while it was import. We just have import, of course. And it went down here in the early 70s very quickly. And I come back to that time schedule later on. We will probably hear more from Carol about the different products you have for asbestos. I have just given them here in 4 typical groups. You sometimes forget that thixotropic capacity has been an important reason for why painters also show up with mesotheliomas. It is much more understandable that asbestos cement and insulation gives the exposure. This carpet, the floor carpets, have a lot of asbestos because it was alkali resistant and it was also a kind of reinforcement structure. And you will see later that floorers also have some excess in mesothelioma. What is a problem here, which is not understood, I think, by everyone, is that the major ultimate asbestos end user is in construction industry. And that is not only in transition economies like yours, it is in every type of country. So construction uses a majority of the asbestos-containing products. At the same time, construction has, to a very high extent, belongs to the informal sector. And you know how difficult it is to assess problems, retrieve patients from the past, so to say, in informal sector. And I think this is one of the reasons why it has been forgotten so long, that this is a trade with a major problem. We are back here to this Swedish import curve. This little P going down is probably when the shipyards decided not to use it any longer. And then we have a very rapid decline over less than half a year. And that was a result of our own findings of mesothelioma in this population in our cohorts, showing the employers and the employees, and they together decided, just directly, we don't use that products any longer. We just get rid of them. And then, of course, there was no reason to import the asbestos and produce the asbestos cement products. It was a very quick action by the social partners that later was followed up, of course, in forms of legal requirements by the authorities. It's interesting to see here that by that time, we have not gone very far in terms of the increase of mesothelioma cases in the country. It was just because we have the surveillance system ourselves in the multidisciplinary service structure which I was working with, that we were able to tell them this truth. And now, as you can see in the next slide, this level of about 100 a year has continued, and it has continued even up to 2009. Women are more or less the same level all the time. So around 370,000 examinees of our construction workers showed that those who were heavily exposed, and I will show the 6 groups later on, has more than 3-fold excess of the pleural tumors. The other professions has some. And altogether, construction has a high figure. What was important to observe was that when they were asked about their exposures during the health examinations early on, before all the asbestos discussions had come up, only 13 out of 85 knew that they were working with such a product. It was only those who saw the label Eternit as an example who were. All the others were not. So it's not surprising that it took a long time to realize that asbestos is almost the only cause of mesothelioma, because people didn't know that they had been exposed. This one is just to show that the highest incidence is found by those people in my own birth cohort, 30 to 39, if you just forget about these very old ones. Those who were born after 55 in our country, which means coming into the trade after the cessation in 76, do not seem to have any mesotheliomas in the, say, 50, 55-year age group. They had already so early in previous birth cohorts. This is a very important slide and which is usable everywhere. You remember that we had around 20, 25 fatalities by accidents a year in the beginning. These are 5-year aggregates. And then we have very few mesotheliomas. But this period from 95 and forward, we have the same number of mesotheliomas in this cohort as we used to have fatalities by accidents before, while the accidents are down to, as I said, 1 a month. So it is a very important contribution to the health and survival problem in construction workers. These are the 6 groups which I called the excess groups, and electricians is a very surprising group that has turned out to be more and more in focus. I mentioned the floor layers, there are few, but they have a problem. And what is interesting here is that the large numbers, although not the large frequency, incidence, is coming among the concrete workers and the carpenters. And the fact that managers also turn up is, of course, got to do with the fact that they have gone through the career and had exposure in the past. So if we just summarize here, in our just about 370,000 construction workers examined between 71 and 93, there has been 420 pleural mesotheliomas up to 2009. 20% of all male cases in Sweden since the 90s, late 90s, are in this particular cohort. More or less, you could say, are construction workers, but there might be some construction workers who are not in the cohort. And above all, those born 1935 to 44 constitutes 35 to 40% of all, well, 35-40% of all those born in this period are in this construction cohort in Sweden. And the last diagram I showed you, 80% are not in those typical highest risk groups. They are spread out over everyone, carpenters, concrete workers, etc. So this all sums up to whatever you're going to do to make prevention in construction industry, you have to always come in early, a step ahead. When you are doing the planning, the materials, no asbestos or chromium-6 cements, have the right equipment, as we saw with this construction worker from the past and his successor in the late 80s, and the right equipment. And this would be my final message. Thank you very much, and thank you for permitting me to overuse the time somewhat.
Thank you, and we do have time for some questions. If you could use the microphones and please introduce yourself.
Ethnic differences in accident rates, since I assume there's a changing group of ethnicity-wise of workers.
Sweden is a very strange country because construction workers in Sweden belong to the socioeconomic top class. It was a trade that protected itself in a way. So there has been very little of other groups coming in, except for a period from Finland, but Finland and Sweden, that's so close, and there's no difference in income. So we don't see that. However, the last, say, 5-10 years, it's coming a change here, because with the open European politics, people are moving. It's a free move for work, so lots of people are coming in from the Baltic countries, Poland, whatever, and there you have a different safety culture. That is very obvious, both on the management level and on the construction worker level, which I think will become a problem.
Other questions?
I will be presenting one slide on that in the case in the United States, which is more mixed. So there we do have Hispanic workers, and I have one slide to address that.
Սոսովանիսյան առողջապահության նախարարություն։ Ինձ հետաքրում է հետևյալը, հայտնի է համաշխարհային պրակտիկայից համենայն դեպս նախկին եւ խորհրդային ժամանակներից, որ պրոֆեսիոնալ հիվանդացությունը, ընդհանրապես անհատի մոտ հիվանդությունը զարգանում է մոտարապես 15 եւ ավելի տարի աշխատելուց հետո, այն էլ բավականին չպաշտպանված պայմաններում։ Բայց վերջի 2-3 տարիներին մասնակցելով տարբեր միջոցառումներ, այդ թվում նաև ազբեստի եւ ազբեստոզի եւ ազբեստը պայմանավորված հիվանդությունների զարգացման բորնի հայտնի խորհրդակցությանը, տվյալներ կան, որ առաջանում են բառացիորեն ամիսներ կամ 2-3 տարի հետո, ընդ որում երբեմն հիվանդանում են հատկապես մեզոտելիոմայով եւ ասենք թե ձվարանների քաղցկեղով եւ այլն, նույնիսկ աշխատողների կանայք, որոնք չգիտես ինչի արտահակուստը բերում են տուն, կանայք մաքրում են եւ այլն, եւ հիվանդանում են 2-3 տարիների ընթացքում։ Կներեք, պաթոգենեզի առումով ինձ համար այնքան էլ հասկանալի չի։ Ես ուզում եմ իմանալ Շվեդիայում ինչպիսին է այդ պրակտիկան եւ ընդհանրապես ինչ եք դուք մտածում այ պրոֆեսիոնալ հիվանդության, կոնկրետ անհատի կամ գուցե ոլորտների զարգացման, պրոֆեսիոնալ հիվանդացության զարգացման այդ տևողության վերաբերյալ։ Շնորհակալություն։
Thank you for this question. It's an important one. We can say that with the mesotheliomas here, we are really talking about a very long latency period, up to 35 years, I would say, among these. That indicates probably that we have had a fairly low exposure, and we don't have any asbestosis cases since the 1960s, early 1960s. We have the pluraplax, but as you know, we heard yesterday, is an indication of exposure rather than a disease. But we do not see any of those very quickly developing mesotheliomas. It's a very long latency period. And you, Sverre, you might have some comments from Norway as well to this question, or? No, it was.
We have done surveys in Norway as to the latency or development time for mesotheliomas. The recent, I published a paper in some few years ago on latency, current latency. And we are now running into the tail of exposures. So those getting mesotheliomas today, they always have all low exposure. But as of today, the average latency time from first exposure to development of mesothelioma is 46 years. 46 years.
Thank you. Was there one more question? Or? Yes.
But we never had any short term. If you have short term development time, you haven't identified the exposure back in the early time. That's probably the explanation.
Կներեք, ես պատահական արտահայտություն չարեցի, ես լսել եմ մանրամասն զեկույցներ, այդ թվում նաև Մեծ Բրիտանիայից, մասնարարպես նույն Շոտլանդիայի տվյալներով, որտեղ պարզապես այնպիսի չարվորակ ընթացքով գնացող մեզոտելիոմաներ են եւ կանանց մոտ հատկապես զվարանների քաղցկեղ, կոկորդի քաղցկեղ եւ այլն, նույնիսկ ընդեղի լսարանը ինձ համար էլ ես ինչ չեմ համարում այնպիսի դեպք, որ վիճարկեմ ենթադրենք Մեծ Բրիտանիայի մասնագետներին, բայց արտահայտություն եղավ, որ այսօր Մեծ Բրիտանիան առաջատար է, ճակերտների մեջ վատ առումով առաջատար է, եւ ներկայացնում են տվյալներ, որ բառացիորեն 1-2 տարի հետո կարող են առաջանալ եւ այդ աշխատողները բավական է մի քանի անգամ շնչեն ասբեստի փոշին եւ արդեն կարելի է հերթագրվել գերեզման գնալու համար։ Այսպեսի տպավորություն ստացվեց, ասեմ ձեզ ոչ բոլորին դա այնքան էլ հասկանալի եղավ, ընդ որում դա կապվեց, չգիտեմ ինչի ապահովագրական կազմակերպությունների ֆինանսավորման հետ, որովհետև հարցադրում է այդ ժամանակ այդպես էր այն ծանրաբեռնվածությունը, որը կա ֆինանսական մարմինների վրա կապված ասբեստոզի եւ ասբեստով պայմանավորված հիվանդությունների վերաբերյալ։ Ես դրա համար հարցս տվեցի։ Արդյոք դուք համարում եք, որ այդպիսի կարճատև ժամանակում հնարավոր է թեկուզ եւ ասբեստի, թեկուզ եւ բավականին ոչ լավ պայմաններում, չպաշտպանված պայմաններում պրոֆեսիոնալ հիվանդություն առաջանա, որպես պրոֆեսիոնալ հիվանդություն առաջանա 2-3 տարում։ Ըստ ինձ, ես նորից գիտնական չեմ, բայց փորձ ունեմ բավականին, հայտում նաև ընթերցանության փորձ, ագին կարդում եմ եւ ես չեմ պատկերացնում, որ եթե չկա պրոֆեսիոնալ թունավորում, այսինքն միանվագ ազդեցություն ինչ որ քիմիական նյութի, ապա ընդհանրապես քիմիական մասնագիտական հիվանդության զարգացման համար դա շատ բավականին երկար ժամանակ է պետք է նայել դեռ ինչ պայմաններում է մարդ աշխատել կամ ինչ այլ կողմնակի գործոններ եղել դրա համար։
Well, I don't think it was a question maybe directly, but I mean my point here is that with our construction workers, it is a long latency period, and it seems as if, as I said, my own birth cohort that came into work when the import had started to go up, they have developed the disease. Those who were born after 55 and were around 20 when we had stopped this abrupt stop, they don't seem to have the diseases coming up during that follow-up period. And that's the only thing I can comment on from our experiences here related to construction work. Sure.
It is, I just wonder if the reference made by the British was to the duration of exposure. Duration can be very short, but the disease does not develop at the end of exposure. It develops in 30 or 40 years after that exposure. So that short duration exposures are associated with mesothelioma, but not immediately with pathology.
I would also like to add something because at WHO conference on asbestos as economic costs of the consequences of the occupational exposure to asbestos, the experts from UK presented their data and economic costs. And indeed, you are quite right, the duration of exposure can be quite short, and it can be still developed mesothelioma or asbestosis after a required period of latency. So it was not after a year or two developed, it's the duration of exposure. And the data can be found at the link which is available for the participants of WHO meeting on asbestos, but I can also give it to the persons if they are interested in this data. Unfortunately, no one from Armenia attended the meeting, so we are willing to give the link because all these data are there and all the calculations.
Thank you. I'd like to go ahead because our next talk is also on asbestos, and I'm sure it will generate even more questions. Would you consider holding your question? Okay, one quick question.
Շնորհակալություն Լիլիթ Ավետիսյան, առողջապահության նախարարությունից։ Ես ուզում եի հարցնել համաճարակաբանական հսկողության մասին, որովհետև այստեղ ներկայացվեցին տվյալներ հիվանդացության։ Ես ուզում եի հարցնել համաճարակաբանական հսկողության ինչ տեսակ է իրականացվում, ուրեմն հետազոտելու տարածվածությունը եւ ուրեմն վնասվածքների եւ հիվանդությունների եւ քանի որ բազմա պրոֆիլ է այստեղ, հա, տարբեր ոլորտների խնդիր կա, ինչպես են տվյալները ինտեգրվում մեկ համակարգի մեջ եւ այդ հսկողությունը, այդ տվյալները ինչ աղբյուրներից է ստանում։ Շնորհակալություն։
If I'm talking about our system that started in 1969-70, it was a kind of very comprehensive medical questionnaire addressing both respiratory questions, back pain questions, and what have you. We had nurses in the first row, and with those cases where you had a problem, we had them referred to our own physicians who came out into the fields regularly. So what we have been doing in the, let's say, analytical part of the surveillance has been to look at different sets of questions or different measurements like spirometry or hearing capacity, just due to the problem that was under study. But we also, in Sweden, like in Norway, have had a cancer registry nationwide since the late 50s, and we have been able to link to that to see about these type of diseases, which we would not be very likely to meet and detect in our health surveillance system. You need a very close cooperation with the National Health Service facilities for that. And that's probably where you have a problem when construction is in large part informal sector work. You would not be able to catch them. So it's difficult to give a very simple question to your answer to your question, but I try to outline.
Thank you. Our next speaker is Dr. Carol Rice. Dr. Rice is Professor Emerita from the University of Cincinnati Department of Environmental Health. She's an occupational hygienist and has practiced professionally and in academic research and training in worker health and safety education. She has a special interest in the use of historical exposure data to reconstruct past human exposures in occupational epidemiological studies. She organized the multi-state, multi-institutional Midwest Consortium for Hazardous Waste Worker Training, which includes site workers, emergency responders, and workers in a range of industrial settings. It also serves the needs of minorities and low-income residents potentially impacted by hazardous materials in their neighborhoods. Dr. Rice will speak to us today about asbestos, some more about asbestos, and other man-made mineral fibers. Thank you.
While we're getting the electronics set up, I'll take a minute to say thank you for the invitation. This is an absolutely wonderful conference, a beautiful country, and not one that was really on my travel plans. So this is a very pleasant experience and a wonderful discovery. Today I was asked to talk a little bit about asbestos and other fibers in construction. Based on some of the conversation yesterday, I inserted a couple of slides about, unfortunately, this is a US study, but it's the first really systematic report that's been presented in the United States on the cost of occupational injury and illnesses. So that it's estimated using a lot of different data sources and economic models that the annual cost for injury and illness in the United States is $250 billion, which is pretty much every week. And essentially, one of the reasons that we have a problem in the United States in terms of getting changes implemented is that you can see in the second part of the slide that the cost that this cost is not borne by industry or workers' comp. It's really borne by society and the family. So the movement to try to enforce things through workers' comp or through the employer is not a terribly effective pressure point. It's also informative to look at disease category for these costs, and you'll see that occupational injury and illness across all disease categories that were considered by this economist researcher ranked number 2 in terms of the disease burden in the United States. So only cardiovascular disease at $432 billion annually was ahead of occupational injury and illness. We don't rank that high in the federal budget in terms of prevention, surveillance, remediation, but it is a very important drag on the U.S. economy. While the numbers would change, my guess is that that's true in other countries as well. That, you know, depending upon the social insurance system, more of it is paid centrally than in the United States, but it still is a very important contributor to healthcare costs in any country. So the source is here, and you can look at all of the data more. In construction, there really are different purposes for construction. New building, I think, gives us one unique opportunity for prevention and a solution. Renovation, reconstruction, and demolition is kind of a different category, so I'm going to separate those out in this talk. Asbestos is really quite pretty. It's also deadly. The picture here that is brown is amosite asbestos, sometimes called brown asbestos, and the white fluffy stuff is chrysotile. But it's not just dust. There are a number of international programs to ban asbestos from use. The Collegium Ramazzini has a statement on this. The Basel Convention that was mentioned yesterday does categorize asbestos as a toxic waste and does oversee transportation across borders, and Armenia ratified that in 1999. For asbestos, because of the wide range of diseases that you've seen that asbestos causes, really our goal is no exposure. There is no good asbestos fiber to be inhaled. There will be debate, and the Canadians really led this debate, that chrysotile is sort of the safe asbestos, but it's not. It may be, some people do believe that it has less toxic effect than amosite or some of the other amphiboles. However, it's not safe. And if one characterizes it as safer than another one, that's quite different, another type of asbestos. That's quite different than saying it's safe. The exposure occurs to workers. Importantly, it occurs to their family members, as you just heard about carry-home exposure. And it occurs to community residents. So that, and that's one of the exposure groups that can be very important, I think, here in Armenia from some of my observations. As an occupational hygienist, I'm sort of bound by duty and ethics to always go back to the hierarchy of control. We believe as hygienists that the preferable kind of control is to eliminate or substitute, and substitute with something safer. That those are better alternatives to personal protective equipment and other kinds of practices that rely on many other people to implement. If we can remove the hazard, then we have won the game. And that's sometimes true. Hopefully that will be true eventually here in new construction, but dealing with the hazard, preventing and reducing it, will include in demolition and in renovation, will include containing the hazard. You saw the photo of asbestos abatement workers in respirator and white Tyvek clothing to prevent them from inhaling it using ventilation and work practices. In new building, no asbestos will lead to no exposure. If you can substitute another product, that would be the best alternative. There are particular substitutes that are available and have been listed. I'll show you some for insulation purposes, for soundproofing, for damping the vibration in flooring, as was discussed, and for general construction materials. I don't need to go over these. You can read them when they're on the website, but asbestos cement pipe can be substituted with ductile iron. There's a project here in Armenia that I'm going to show you that is doing that. Clay pipe is a very good conduit for water as well. The exterior surfaces do not have to be asbestos board. They can be other kinds of fiber cement or brick, and roofing materials are available here that are a vinyl material or metal that could be used instead of the asbestos cement. There are thermal insulation substitutes, refractory brick, refractory ceramic fibers, high temperature soluble fibers, fibrous glass, slag wool. Now none of these substitutes come necessarily with a clean bill of no hazard at all. We have shown in one of our longstanding studies on refractory ceramic fibers that there is a risk of pleural plaques from RCF independent of any asbestos exposure. Pleural plaques are not a debilitating health condition. They've always been characterized as a marker of asbestos exposure, but they can be a marker of other fiber exposure as well. Silica has its own hazards that we saw yesterday, and there can be metals in the slag wool. But these hazards are easier to control in general than the asbestos. There are substitutes sold here in Yerevan, and I was very lucky to have Rismi, who's sitting here and can hopefully help me answer questions, take me to a supply house here in the city where we found fibrous glass in several different products. The problem or the barrier to using this is cost. It's only imported in certain sizes from Germany. All of these products come from Germany. One of them, however, is just a fabulous alternative to some of the asbestos products. It's adhesive on one side and fiberglass on the other, so that you can actually adhere it. It's self-adhesive to a surface. There are even longer listings of substitutes that will be available on the website. Renovation, construction, and demolition, we use these factors of the date and the use of the structure and maintenance as some indicators in the United States. I think they're pretty universal in terms of trying to sort of figure out the risk. If you know when asbestos materials were used in construction, then you can have some indication as to whether or not it might be a hazard in the structure. Here, they have been used and they're continuing to be used, so that's kind of off the table. Maintenance and upkeep here, I think, are going to turn out to be one of the critical determinants, and I've got a couple of pictures of that. Now, so that we all stay awake, one of the uses is spray-on insulation. How many of you have seen this used in Armenia? Was this ever used here to spray on structural steel? I don't know. But if you see this, be aware. This is asbestos on pipe as pipe insulation and not being well maintained. A very big part of dealing with asbestos is the awareness that you have asbestos, and looking at pictures imparts that sort of starts to develop that sensitivity. Here's some poorly maintained heating pipe asbestos insulation that could be in, for example, this could easily be in an apartment building where there are several apartments. This is actually a product where you can see, if I can make this work, that there's asbestos here. This is fiberglass with a covering over it. So it's kind of a mixed package of insulation material. And I think that is sort of similar to what we see in this picture that I took in Yerevan. And there's a very long outdoor conduit here that has been insulated, but due to the factory closing, there has been no maintenance, and you can see that it's falling by gobs into the trees and onto the ground. This is a hazard to any children who go play there, and ultimately the asbestos part can become part of the soil and can be a community exposure concern. This is what it looked like in the United States, putting in asbestos insulation early on, and there, in many of those closed factories, I would wager this would be seen. When you see this, remember, it's not just dust. Cleaning it up, moving it, you see this is not a good procedure. The person has work clothes on that will go home, so somebody else will be exposed in the house. A child will come up to this workman when he gets home, hug him around the legs. Where's the most contamination of the clothing? Right in here. Somebody will shake the clothes out before they wash them, so everybody's getting exposed. Roofing is a really important exposure route, I think, here in Armenia. It is used widely. When we went up to the monasteries on Sunday, there are entire towns that are asbestos cement roofing. You've seen grinding photos of it today and yesterday. Here's somebody sawing it. Not good. Drilling. Each of these operations generates dust. If an operation has to be done that can generate dust, the workers have to think about how that can be reduced. You're not going to get everybody immediately to not use this kind of roofing. But wet methods, using water, spraying things with water, and something called amended water is a control. And amended water is simply 1 cup of soap, dishwashing soap, added to 200 gallons of water. So, and there's a resource at the end of this talk that you can look all this up in. But keeping things wet reduces dust. We know this on roadways. We know this, that if you're dusting at your house, you prefer to use a wet rag rather than dry. And it's not any of this is rocket science. This is a gasket around an oven that has become frayed, and this is what it looked like originally. So you can see that it became affected by the heat and was torn. This is asbestos cement pipe. So there are 2 dangers with this. One is in cutting it, which is this picture. And the other is that it's used for water. So water pipes can be delivering water to your house that are asbestos cement. Over time, the pH of the water starts to act on the cement, and that liberates the fibers into the water system. And that is one of the projects that's going on in Armenia. So I have 3 examples. In this village, asbestos cement water pipes are currently being replaced. And should be, and it would be a good project for students to follow up with to see if that's been done. Because according to the internet, by June 2013, the project should be over. So even if it's behind schedule during the summer, you would hope. Roofing has deteriorated, not only for the chickens, but also for housing. This, I was told, just anecdotally, that when people remove this, either to replace it with new asbestos cement or to replace it with a good substitute, that it's put into sort of a community location and other people come and take it away. that's not good disposal. When the asbestos cement pipe is, roofing is removed, it really should be removed using wet methods. It should be removed by people who don't get a lot of it on their clothing and take it home, and then it should be buried. It is considered hazardous waste, and it should be buried the prescribed number of feet under the ground so that it doesn't come back up. There's currently a fairly large agricultural irrigation project going on here that illustrates another use of asbestos that I don't have a picture of, but it's used in the pumping stations to help insulate a number of the transfer points. This project has actually required that anyone participating, any of the villages participating in this project with more than 1 square meter of asbestos to be as part of the removal and renovation project, do asbestos abatement the way that it would be done in the United States. I was very surprised as I was trolling through the internet that there are asbestos abatement companies that say they do business here. And I suspect it is driven by, it may be driven at least in part by this project. But it requires that you recognize the hazard, so that means that you really do have to have your eyes calibrated first. Then you can take a sample, and there are microscopic methods to identify it in the bulk material. All of the workers have to be trained. Part of the training is in work practices that reduce exposure, the proper use of personal protective equipment, which is sort of the full garb that you saw in the photo in the previous presentation, how to decontaminate those people so that you don't just come out, take the respirator off, take the Tyvek off. You actually go through a shower. That water is collected because it is also hazardous waste. Construction substitution is definitely the best alternative. As the first step in renovation, demolition, and reconstruction, you have to recognize that you're using that there's a hazard because asbestos is in place. The barriers are great. It's not everyone has been trained to recognize the asbestos, although I suspect a lot more people know that it's there than I'm aware of. There are competing priorities in health and safety. We had mining all day yesterday. There's asbestos today, and construction. Money is clearly part of the problem or the barrier. Regulation followed by enforcement and training are certainly our tools to achieve the goal, but I think waiting for regulation and enforcement is it's not a tool that is useful in the United States, and if it's useful in Armenia, that'd be great, but I think we're all pretty much the same. So I think that raising awareness and having workers who are using these materials involved in developing a plan to reduce their exposure, to make sure that they have water, that they do have something to add, some soap to add to the water to make amended water, that they stand with the wind at their back instead of at their front, that they don't take the clothing home. There are many things that, in my experience, when we get a group of workers together, they know the constraints of their job. And if they're brought together and aware of the hazard of asbestos, they will come up with ideas that they know they can implement. My ideas of how they should do their job are, I don't do the work every day. I can be an expert, but I have no idea about their real work. And I don't understand the constraints on their life and how it's programmed, whatever. So having workers develop a plan to reduce exposure, maybe not eliminate it. There's no good asbestos, but less is better. And all of these things should go along simultaneously. Don't wait for regulation. Thank you.
Խնդրություն Սևոյան Սիլվա։ Ես կխնդրեի ներկայացնեի, ասենք, ազբեստի փոշու լվացման կեղտաջրերի հետագա մաքրման հարցը։ Դա ինչպես է մաքրվում ու ասենք ուր է դա մտնում է ընդհանուր կոյուղու համակարգ հետագայում թե չէ եւ ազբեստի այդ շիֆերները, որ ասենք տանիքները, որ հանում են, դա որ պետք ասենք հողում թաղվելու դեպքում այդ տարածքներում որևէ ասենք բուսականություն, կանաչապատում թույլատրվում է թե ոչ։
Yes, thank you. Regarding, see, the first part of the question already escaped me, but we'll start with the back end. The water, yes, there are filtration systems that will take the fibers out of the water. That filter then becomes hazardous waste and is treated as a hazardous waste that would be, you know, generally what you would probably do is the filter would go into a plastic bag and that would be buried. Just as the asbestos cement would be encased in plastic before it's buried. Just to prevent you from getting more contamination as you go to the hazardous waste burial site. This should be buried, you know, a meter or more under the ground. So I wouldn't have any problem having a garden on top of that because the roots for my vegetables don't grow that deep. And as long as it's not disturbed and you don't bring a backhoe in to dig really far down in order to build a new structure, for example, it should be fine. And I don't know if there are designated hazardous waste disposal sites here. Nah, just bury it. It's better underground. That's where it started.
You mentioned the substitute of asbestos, among them man-made mineral fibers as ceramic fibers, glass fibers, and so. In our laboratory, we tested more or less 15 years ago the substitute of man-made mineral fibers, and if we had in our experimental model 80% of mesothelioma induced by asbestos and all the type of asbestos. In man-made mineral fiber, we had 40-60% of mesothelioma in our experimental. In fact, at that time, Maltoni raised the question of the substitute of asbestos, and he emphasized that, saying that maybe in the future we can should take in consideration not anymore the mesothelioma from asbestos, but from the substitute.
It certainly has been raised as a concern based in part on your observations in the laboratory. We've been, Jim Lockey and Grace Lemasters have headed a project for the past 25 years at the University of Cincinnati, and I've done the exposure assessment for it. We have not seen a mesothelioma, and this is a cohort of all of the production workers in the United States. It's not a big number. And we did exclude the employees at the two companies where that had been asbestos processing plants before they became ceramic fiber processing plants. So they're relatively clean exposures. And to date, we do have a mortality registry. To date, there has been no excess of lung cancer. So based on, and we're continuing to follow it, so you know, there will be updates. based on a number of concerns in the European Union about refractory ceramic fibers, the fiber chemistry is right now undergoing a substantial change. And the new fibers that are being manufactured are soluble in pulmonary fluid. So that's a new fiber. And it's not a refractory ceramic fiber. So that's going to be a new wrinkle, but we're going to continue to follow the RCF workers.
We have time for one more question.
There are so many different forms of asbestos, and it's so widely distributed in the countryside. What about training community leaders to recognize that? Is this feasible? Has it been done?
I don't believe it's been done here to train community leaders regarding the hazards of asbestos. Community leaders, I think, are certainly part of the mix for training. And it could be very important in terms of cities and villages where there are substantial numbers of closed industrial plants. And, we saw like whole river valleys that basically are now old industrial facilities where much of the iron, the cast iron, has been removed. But I think inside, when there is a remediation to use that land for another good purpose, there's going to be asbestos exposure to whoever goes in there in all likelihood. And community leaders need to recognize it, and the workers need to be actively involved in assuring that their exposures are as low as possible.